Well, again, this is Carl Buell. I'm the host for today's webcast, Improving Process Standards in Healthcare, at 7:01, so we promised to start at 1 minute after. Excuse me. So let's go ahead and proceed here. Again, my name is Carl Buell. I am your moderator, former software exec and consultant in business development. In the healthcare arena I've grown a healthcare startup from concept to 15 million in sales, and formerly a Microsoft exec from 90 through 97. We're also joined by Ashok Joshi. He is going to be our Q&A monitor today. Ashok is co-founder and director of Synopsys Technologies. They do software development, and they do it for small, medium, and some large companies that you see here. Our guest speaker is Dr. Pankaj Gupta. But before I introduce him, let me just talk a little bit about some housekeeping issues. Attendees are muted. If you have questions as we go along here, please type them into the Q&A panel. We will handle Q&A at the end here. And so I'd like to introduce Dr. Gupta. He is our presenter today, and he is a medical doctor with extensive experience in consulting, IT consulting, and healthcare management experience. He's worked extensively in the U.S., Canada, and India. He's licensed in India and Canada, and has worked with several large companies that you can see there. Dr. Gupta, you have control. Please take us through improving process standards here.
Well, thank you, Carl, and I'm happy to be presenting this to a pretty large audience with a room full out there, and happy to see that, people are so interested in this topic. So today we are going to be talking about process compliance and process standards like BCMA, CPOE, and a couple of other as we will talk. But over time, we will also have other webinars like semantic compliance, interoperability, security and privacy, meaningful use, stage 1 and stage 2, and things like that. Well, these topics are quite interrelated, and there's a lot of overlap. So it's hard to put a solid line and say that, these are the things which will be handled in one webinar versus the other. So there are going to be overlaps. However, we will try to keep it in a way that, we deal with the overlaps where required in the webinars, and defer some of the topics to the next webinar if we have to go deeper into those topics, which belong to the other bucket, so to say. In terms of topics for today, we're going to be dealing with lean process thinking, CPOE, computerized physician order entry, eMAR. Under eMAR, it will also contain barcode medication administration, CDSS, which will include key performance indicators, trends, and evidence-based medicine, device workflow integration, and then if we have time, we will try to cover other workflow considerations as, have been said by meaningful use. Lean process thinking is basically about removing unnecessary loops and kinks and redundancies into the processes so that, you can achieve the benefits. What has happened over time is that closing the loop has remained a challenge. Most of the enterprises today are struggling with enterprise-level integration between different softwares and devices. However, the real benefit comes when you close the loop in terms of getting the feedback from what you have done, so that you're sure that the things that has been done in the right direction. And that's where you have CPOE, evidence-based medicine, dashboards, and trend analysis. So I have seen some implementations where the personalization and web-based portals, mobile platforms are happening. However, most of the industry still is struggling with enterprise-level integration. So there's a long way to go before we get the benefits, and hopefully meaningful use will take us there. Why lean thinking is required in healthcare? Well, healthcare suffers from waste and inefficiencies in multiple ways. So there are cost pressures. The healthcare costs are rising. There is a large uninsured population. You have patient safety concerns, baby boomers, and so on and so forth. In addition to that, now the additional burden of compliance to meaningful use. Some of it is likely to get offset by the incentives from the government. However, not everything will get offset by that, and you will have to do additional process optimization so that you can reap the benefits of that and cut costs over time. And that is why lean process thinking becomes extremely important. What is lean? Well, lean started out a long time back in early 1990s by the Toyota, because Toyota is known for its lean thinking. It was able to transform the automotive industry the way it produced its cars and other vehicles. And then, after that, it has been implemented in other industries, including healthcare. Healthcare has done some good implementation, and they've got benefits out of it. What really is lean? You specify the value at the end of a process, what is the value that you want to get. You identify the value stream. Those are the steps, different steps that you do to achieve the value. You put the steps into a particular flow. Each step pulls the value from its previous step in the value stream. And then by doing all this, you try to achieve perfection. That's what is your lean thinking all about. Now, what it means is that you have to sort of move from your obsolete processes and move towards a transformative leadership and not really get stuck into existing operational models and incremental improvements, but you need to do a quantum jump from where you are, and then, once you have identified that, this is where I need to go, then do small steps to get to that point. Here is a workflow diagram that I have taken from some of my previous works. You have the physician, the pharmacist, and the nursing doing certain steps, and, from ordering all the way to follow-up. So it is your current state. Take a model hospital and you map out this process diagram. It becomes your current state. Once you've done that, then you look at the different boxes out there which are representing some processes or sub-processes and say that, can I remove the defects? Can I remove the waste in some way? Are these boxes really required? Can I remove some of these boxes and still make the process work? That is the kind of thinking you need to bring in. That's called the lean thinking. You go on removing the boxes, changing the workflows in a way that, you still achieve the value in the end by limiting or reducing the number of boxes, number of sub-processes that you really have to do. Once you have done that, then you achieve your 2B or your future state. Now, this future state is nothing but your roadmap or your, blueprint that you need to achieve by doing the various steps of implementation in your organization. And the blocks or the sub-processes that you have removed are the ones that, you will work towards in terms of change management. So people change management, process change management, and technology change management. so that, you put all of that into it and change the things one by one. And whenever you are making such a large change is always expensive. However, you also have to put in or institutionalize change management. Before I talk about change management in more detail, I wanted to talk a little bit about what are the different kinds of waste. So, in healthcare, you have different waste. You have defects, you have overproduction, transportation. Many times people are being transported where it's not really required. Movement, lots of movement happens, or unnecessary movement happens in hospitals, which can definitely be avoided. Movement in terms of people, equipment, and everything else that is movable pretty much gets moved around, even though you may not require to move it. So leaner your process, lower the cost. Waiting time, huge issue in healthcare. People just keep waiting endlessly, and the waiting line, if you can reduce it, you always save waste. Inventory, again an issue in healthcare. People tend to have large inventories kept in various stages, from your main store all the way to your local store and your patient area. People tend to store a whole lot of things. Rather than that, if you can move toward just-in-time kind of a model, where you get what you require just in time, but to do just in time, you need to have processes to support it so that, it gets delivered to you when you require it. There are certain lean challenges in healthcare. In healthcare, there's no tangible product. What you're offering is a service. Positive outcomes are not always guaranteed. That's the way healthcare is. Who is the primary customer has always been a question. It continues to be a question. Is it the patient? Is it the insurance who is authorizing the payment? Or is it the payer who is actually bearing the cost? Different by design, because surgical procedures are never done exactly the same way. How can you say that, in one surgical procedure, it took longer than what it should have on an average? Well, it just did take longer, right? Similar by exception, in psychologists, when they are actually, having a session with the patient, it takes, some of them will take long, some of them will be short, and they really don't do exactly the same thing in two different consults. Emergency medicines and high-end antibiotics are supposed to be just kept, and they're to be used only by exception. So this is a waste by design. So if there are people or consultants who don't understand these healthcare challenges, and they are used to implement lean thinking in a hospital, you're going to end up in a disaster, because you need to have healthcare people having healthcare backgrounds to have the lean thinking and implement the lean thinking. I have seen hospitals where I've worked where, consultants came with MBAs and having zero healthcare background. They came and implemented some of these processes, and at the end they found that, they missed out on certain very important healthcare considerations, and it became an issue. Well, in healthcare, the processes are very dynamic, unlike many other industries. So I always say there are three things in healthcare which are dynamic. One is the process or the workflow is dynamic. Second one, the terminology is not standardized. And third, the business rules are always varying from department to department and physician to physician. Now, how do you deal with that? It's always that's the reason healthcare is so challenging. So you have to institutionalize change management when you bring in lean thinking. Now, over the years, having done this again and again, we have come up with a methodology called cause methodology. It is consciousness of the need to change. That is, the people need to have the consciousness that they need to change. It has to be brought by the top management. Second is aspiration to support change. Well, consciousness is not enough. They need to have the aspiration from inside that I will support the change. Once the aspiration is there, then it's all about training, making them understand as to how the change will happen. No change happens without hurdles. You need to have the strength built into the organization to overcome the hurdles. And always, this strength is borrowed from the CXOs of the organizations or the top management. They are the ones who have to be solidly supporting the change, and when there are hurdles, they are the ones who should be helping in removing the hurdles. So strength of overcoming the hurdles has to be there. And all this hand-holding has to happen until the system reaches an ecosystem. It becomes self-sustainable ecosystem. And if the support is given to it till that time, then for sure it will not swing back. However, if it has not become an ecosystem, then the change will not be permanent and it will swing back. And that is why you would see a lot of projects that did not have a good change management built into it, did not succeed. A lot of time, IT implementation stopped once the UAT is done. UAT is, user acceptance testing, and after that, the IT company says, okay, I'm done, but then the pain actually starts at that point in time. And that's where, the contract needs to have the change management built into it, but most of the contracts I've seen do not have that built into it. Change happens in small steps. It does not happen in a big way. And the combination of fear and rewards leads to habit. And small fears, small rewards, it's like a child being taken through the process, and slowly, when the child is made to do the thing again and again by a combination of fear and rewards, it becomes a habit. Same way, all the users in a healthcare organization are like children experimenting with new things which are coming, new processes, new devices, new integration, and new way of doing things. And they have to be dealt that way, gently with kid gloves. If you institutionalize the business process reengineering right in the beginning, then you tend to gain the benefits over the years. However, if you bring it somewhere in between, you do not get that kind of benefit. And if you don't bring business process reengineering at all, and you continue to, deal with the process challenges, the meaningful use, and the cost pressures which are there from the industry, then, your overall cost continues to rise. So pretty much, the providers today have no choice. They have to do business process reengineering, bring in the lean thinking so that, the cost can be brought down over time. Let's take a couple of examples from meaningful use. Computerized physician order entry is one, in which we all know that, meaningful use says more than 60% of medication orders, more than 30% of lab orders, and more than 30% of radiology orders need to be in the CPOE. So, you have to have an electronic system to do that. We know, almost all of us in this will know that, what CPOE is, and I do not want to repeat it. It all started by the Institute of Medicine's report to Err is Human, and from that we've come a long way where, the Leapfrog Group was created, the CPOE standards were done, and now that's been adopted by meaningful use such that any system that is compliant to meaningful use should be looking over the shoulder of the doctor and telling the doctor that, these are things that you may want to consider. However, the doctor's clinical judgment is supreme, and the doctor can override and say, well, I don't want to do it, or I want to do it in a certain way. Well, that's fine. Please go ahead. The system doesn't stop you from doing that. These are the standards of CPOE, as you can see on the slide. So drug route, drug allergy, therapeutic duplication. All of that is available on the Leapfrog Group website if somebody is interested. Here's a snapshot of the tool, the evaluation tool. I built this tool a long time back when I was working with FCG, and I'm happy to see that it's still being used by the Leapfrog Group. So, that's an interesting thing out there. In terms of challenges, let's jump to the challenges of CPOE. What you get paid for, the incentives, is the implementation and not the product. I was asked by a couple of consultants that, when the products are compliant to meaningful use, when the products are compliant to the ONCHIT requirements, why does the provider have to go through all the implementation and take the burden for getting the incentives? Well, you have a multi-product environment. Rarely you will have a single product environment. And the product vendor is going to be responsible for only his or her own product. They're going to stop where the boundary actually crosses over into the other product. And when you have different systems working together, the responsibility of different systems to work together comes on to the provider. And someone in the provider has to don the mantle of meaningful use consultant and make things happen across different eMARs. And those different eMARs could be in related groups of hospitals or unrelated, or it can be outpatient and inpatient, labs and radiology getting orders directly, and additional orders being given while the procedure is being done. Ultimately, you have an issue about the denominator. So, the numerator and denominator that has to be calculated. So the denominator becomes elusive if these are multiple systems. And that's a challenge. And it's a challenge which can't be really, you can't ignore it. You have to deal with it. And you need help, you need consultants who can actually sit down with you. Now, those could be in-house consultants who are groomed over time, or these could be consultants who are taken from outside. However, the denominator is something that has to be calculated. In terms of confidence level versus ROI, once you've implemented CPOE, your confidence level is definitely going to go up. However, are you going to get the ROI, or can you calculate the ROI? That has always been a challenge, because when you're going on the right side of the road and you haven't caused an accident, how can you put a value to an accident that never happened? And that's exactly what I always tell. How do you calculate the ROI of CPOE? It's going to prevent accidents from happening. So how will you put? The only way is historical. You can look at the historical data and say, well, these were the errors that were happening in the past. Now my percentage of errors has come down. However, the errors might have come down just because people have become more aware of it and not necessarily because of the system. So you really can't be sure of that. But, ROI is always elusive, so to say, in the classical terms of ROI. Let's look at the next topic, which is Electronic Medication Administration Record, or eMAR, as it's called. It's again a meaningful use requirement, where it says at least 10% of the medication orders you need to do eMAR. eMAR can be implemented on paper. However, reconciliation between paper registers is always a challenge. RFID or barcodes. I have seen most of the implementations happening by using barcode technology. It's low cost and there is a history behind it of success. So I would say use barcode for implementing eMARs. Everyone in this room, I'm assuming, knows what an eMAR is, and so I'm not going to be spending a lot of time in explaining what eMAR is. Here is a snapshot of that. So basically, the errors can happen at not only the order stage, but it can happen at the dispensing, administration, or any stage in the process from ordering to administration, and you need to have technology helping you to fix it so that, you know, the errors don't happen and you can prevent the errors. What are the challenges? Well, integration issues, data sitting in silos. When you do integration, it's an inefficient integration and data loss happens. Hardware issues, you didn't plan for Wi-Fi, whereas you need scanners and tablets to be moving around, and you have a problem there. Scanners fail, scanners don't record the things properly. Nurses not trained. Retrospective catch-up after emergency, after the emergency has happened, you know, you tend to sort of, you know, dispense the medicine and then say, okay, I'll catch up later. It's an issue. Patient ID bands getting cut off, miscoded medications, empty unit dose packages being dispensed, delivered without scanning, you find damaged barcodes. Many people just override the alerts that come. All of these are challenges. Finally, cost reduction and ROI. Well, it's the same thing as CPOE. If you have prevented the accidents from happening, if you prevented the errors from happening, how do you really calculate the ROI? The only way is historical. Look at the historical data and see whether, you know, you've been able to reduce it year on year. Clinical decision support, again, a meaningful use requirement. I'll not go into a whole lot of details, but, you know, the measure that the ONC has put is really interesting. It says implement 5 decision support interventions for the entire EHR reporting period, must be related to high priority conditions. 1 of 5 interventions should improve healthcare efficiency. What it pretty much means is you have to implement it across the enterprise, across the organization, and then pick up the 5 areas that really make sense. You really can't do it otherwise. So, although they've said just 5 areas, but in reality, you'll have to do across the organization. And this pretty much will lay a lot of pressure on the organization because it'll have to be structured in a way that the organization is able to give you key performance indicators from all the disparate systems and feed it to dashboards. Once it is fed to the dashboards, then the decisions can be done. Now, the dashboards will have to be at the disease level, at the practice level, department level, hospital and the region level, and the executors should be able to make those decisions. But to do that, a whole lot of people, process, and technology change management has to be done. People have to be trained to be able to get you the KPIs in time. You have to put the process in place so that, you know, things happen and the KPIs are becoming available to the dashboards. And of course, the technology component has to play its role so that all of this can be put together. Evidence-based medicine is all about analyzing the past clinical data so that, you know, it can help you make better decisions. Now, all the data can be put into cubes. You can have the slicing and dicing of the data in different shapes and sizes, and depending on, you know, whether you're looking at it from a laboratory perspective or a pharmacy perspective or radiology, or, you know, you want to look at it signs, symptoms, diagnosis-wise, whether you want to look at it from a department level or from a hospital level, is something which is made available to you once you have all the data and it's been organized in a data warehouse. What are the challenges? Again, data sitting in silos. I have dealt with large data warehouse projects in US hospitals, and it's always a challenge to bring all the data together from different sources. It's more political than technical issues. Systems are not integrated, data loss during integration. Data warehouse hasn't been created for reports that you want, and once it's already been done, a lot of money has already been spent, then you say, no, I want some other kind of reports. Well, that is not included in the When indicators change, that's another challenge. Cost reduction, over time you can see some cost reduction, however ROI is elusive as explained earlier. Device workflow integration, devices and technology is least visible when fully integrated into the workflows, and that's a statement made by some gurus who have sort of done a lot of device integration, and I completely agree. For example, light bulb is technology, and you don't notice the technology because it's part of your life. What are the challenges? Medical devices, data loss happens because it sort of creates a break in your workflows and processes. Paper forms, printouts, staff training is an issue. License renewals, many times people don't renew the license for integration of the device so that the output can be taken. There are no uniform standards yet for device integration. Some people follow HL7. Radiology, mostly everyone follows DICOM. There's a new standard emerging called Continua, which is being backed by Intel. It's a good standard, however, it's yet to be seen whether everyone adopts it. So no uniform standard per se. Couple of other workflow considerations. I know I am pushing the time, but let me just take another minute to cover that. Patient electronic access, that's a new requirement which has come in meaningful use, stage 2. However, it has also been said that stage 1 in 2014 will have to sort of comply with patient electronic access. The biggest challenge is how do you convince or influence the patient to log into the portal every now and then so that you can be compliant. Medication reconciliation, if the sending facility did not send what it was supposed to, you have a challenge. And then in the process, you need to have a process to match the medications between internal, external, and a standard. Well, what is the standard? That's always something that you have to decide. Transmitting of the data, privacy and security is an issue. Summary of care record, it has to be embedded into the ADT process so that every time if the transition is done or the referral is done, you make sure it happens. Technology-wise, as soon as any data is leaving a trusted organization, then you have an issue in terms of crossing the boundary. Electronic reportable laboratory results, again, it's crossing the boundary, so you have privacy and security issue. And then in the process, what you have to do is validation check, submission. Well, I have that much to say. I will hand it over to Carl, and I will request Carl to take it over from here.
Our sponsor today, which is EffectiveMedTech. We are a healthcare consulting group, and we have deep healthcare experience, management and operations background. I'm going to open another poll up here to just ask you if you would like to learn more about our services. We do technology and particularly software development, focusing right now on meaningful use assessment and meaningful use coaching and training to help companies get through this. So, Kashif, do you have any questions for us on the Q&A side?
Yeah, I see one question. In fact, a couple of them just coming up now. One of them, I think this is quite interesting, which talks about, or probably I'll read it about the way it is. It talks about the cost pressures. We are under cost pressures from all sides, cost of healthcare, cost of implementing MU, and now struggling with lean and BPR. When can we actually see the benefits? I think end of the day, it boils down to when do we see the benefits? Dr. Pankaj?
Okay. Interesting question, and I sort of answered part of it during the presentation. However, when you see the benefits is depending on when you start the change management. The better your change management, the earlier the benefit that you will see. However, it will take time. From the time that you start, it will take anything from 3 to 4 years till you see very good benefits and going through the process. And healthcare is difficult in multiple ways, because when you have to do change management, I have had areas where there were people who were waiting to sort of be the change or be the stumbling block in the change, and we are all humans, and it becomes difficult to deal with that sometimes.
We also have another question. You talked about change occurring in small steps. Someone asked, generally speaking, what's your experience? How long does it take to implement a new technology or process throughout a department? And obviously that depends on the size of the department, but what kind of procedures or training helps with departmental adoption, and how long generally does that take?
Right. What I've seen is in a typical EMR implementation for a 500-bed hospital, the change that you have to institutionalize is clinical transformation, where you bring in clinical people who have done it before, who've seen a couple of changes, to handhold the others and see that they can go through the change. In a hospital that I was working, the nurses actually came forward and said, well, this is additional work that we have to do, and we are not willing to do that. Welcome that when we told them that you're going to be empowered and you don't have to wait for the doctor. Actually, the doctor will be waiting for you. It gives you the power in your hand if you sort of become champions on the EMR. That motivated them, and they really adopted it over time, and they sort of went through all the training and everything. So it was an empowering tool for the nurses, and you have to find those kind of hooks. You have to find those kind of levers to get the people interested.
Great, thank you, Dr. Gupta. Ashok, what's the next question, please?
Well, this is all about technology. I think the biggest question has been consultants really lack technology understanding, and the overwhelming feeling today is that meaningful use is all about technology solutions. So where does this integrate, Dr. Gupta?
Sure. Well, you need people who have experience of healthcare and technology both. You need crossovers. You need people who have done healthcare and technology, whether they come from a healthcare background and then they have done technology, or vice versa. But definitely need crossovers to help you do the change management, to help you bring in the lean thinking, to implement the processes. And I've seen n number of times that it becomes very difficult for people who are not crossovers to understand the other side. Doctors sort of speak very subjective, and engineers most of the time speak very objective. And when you have a subjective language clashing with an objective language, it's a nightmare.
We have a question from David Tolliver. He says, ever-changing healthcare regulation has forced many new requirements on physicians. Compliance is key for a successful practice or hospital. Are there any success stories or focused initiatives that you can share regarding the use of scribes in supporting the records burden?
Yes. The compliance requirements, the regulatory requirements have been changing over time. However, there are certain successes. I am a board member of HIMSS, And I have seen at least 2 hospitals where I worked, they achieved HIMSS, one achieved HIMSS level 7, the other one achieved HIMSS level 5. And that's a whole lot of implementation and adoption. And it takes a lot to do that. And you have to invest a lot in clinical transformation, having clinicians work with other clinicians to make it happen. In the hospital that I was working, the adoption went up to about 95%. And you know, the hospital was able to achieve HIMSS level 7. I won't be able to give you names specifically because I'll have to take permission from them before I say it, but there are case studies.
So David, let us know let me know in the chat window if that's something you'd like to see, a case study. We can perhaps get permission and forward that to you. Dr. Gupta, we have another question about Leapfrog and the CPOE tool. Can you tell us a little more about what Leapfrog is and what that tool is and how it works?
Sure. Well, the Leapfrog Group is organization that was set up after the Institute of Medicine published the report where they said, you know, 44,000 to 98,000 deaths happen every year. And then, you know, large organizations or large employers like Boeing and Ford and a couple of others got together and they said, well, we are the people who are paying for healthcare of our employees, and our employees, when they are under threat because of patient safety, so we need to put some patient safety standards in place. And then, you know, everybody got together, created the Leapfrog Group. The Leapfrog Group then put the standards in place. CPOE is a standard which came out from the Leapfrog Group. You can go to the website, the Leapfrog Group, and take a look. There is a tool out there where, you know, hospitals can log in. It gives you a set of requirements. So it says that, you know, here is an order. It's a dummy order that you put into your EMR system, and whatever is the result that you get, you put that result back into the tool, and the tool does a scoring and gives it to you at the end whether, you know, you are compliant to the CPOE or not. And if you are compliant, then, you know, it says great. And if you're not compliant, then it'll tell you which are the areas you are not compliant, and then you have to work over it. And then that's very useful tool, because once you have done that, then, you know, it becomes easier to comply with the meaningful use requirement.
We have another question, which is, how can we speed up change management in adopting technology?
I again go back to the same thing that I said, that, you know, you need people who have been there, done that. It's very easy for people to get flustered when things begin to go wrong. In a hospital that I was working, we put the hospital onto a cloud. We put it on a data center, and it was a group of hospitals accessing everything from the data center. And when you do this level of change, you know, things are bound to break. And it did break. We had to go over fixing it one by one over time. And there were a lot of people in the organization who started getting uneasy as to, you know, it's breaking every now and then. And my task was basically to assure them that it's okay, we will get across it. It happens. Once you touch a network, it breaks. And once it starts breaking, you just have to go on fixing it one by one. So what you need is people that done that, be able to guide. And once you have those kind of people on board, and the skills that are required is usually a combination of healthcare management and.
Okay, great. Ashok, you have another question there?
Yes, you know, this is one question that even sometimes I keep thinking. It all talks about a provider, let's say, for example, a hospital, One of the biggest challenges with meaningful use compliance is the question of why is the compliance my responsibility and why don't product vendors take it over? Why isn't their burden? So, Dr. Gupta, how do you address that?
Yeah, again, an interesting question. In fact, I have been asked that question in other forums. Well, the vendor actually provides a whole lot of support, but the support provided by the vendor is limited to the product that the vendor is implementing. And barely that, you have a rip and replace or a greenfield implementation where it's one single product environment. Mostly you have a multi-product environment. And there are some homegrown systems included into it, which are sort of have an IT in-house, develop the system. So you have to integrate all of that, bring all of that together. And obviously, to do that, you need a team within the hospital that will take the responsibility of doing it. So although the vendor does its bit, but the hospital will have to take the major share of the burden for the implementation. And it's the implementation for which you get the incentive. It's not really the product.
Great, thank you. Dr. Gupta, you spoke about dashboards, and there's a question about what's the best way to influence our IT department for the dashboard features that we need as opposed to what the IT department thinks we need.
Interesting. I will quote a project that I had done without taking the name of the customer, of course. Developing the key performance indicators is always a challenge. Now, when you give it to IT folks, they are going to come up with a list of, key performance indicators which really don't make sense to clinicians. And when you give it to clinicians to do it, it's going to be such a long list that it's going to become difficult as to which one to take and which one to leave. A normal human mind cannot process more than 7 different parameters at a given time. So you should never have a dashboard more than 7 or 10. However, most dashboards that I have seen have 25 plus different parameters out there. Some even have 200 parameters. Now, who's going to be able to use those many and make some meaningful decision? Now, how do you do it? The only way to do it is to have a governance model, to have a team which comprises of technology and healthcare people, guided by people who are crossovers between healthcare and technology, so that you can have KPIs that are meaningful, and then you sort of develop it. The other challenge is that you don't have any dashboards which are pre-populated for healthcare. If you bring in a dashboard company, a typical data warehousing BI company, they will come and develop all of this when they start implementing, and that's the way it is. Or the other way is to have a group internally do the preparation in terms of what KPIs you need, and then invite a data warehouse BI company to do the implementation. I would say the best one would be that you do your homework before you bring in the technology company to do the data warehouse.
Dr. Gupta, another follow-on question about dashboards and key performance indicators, and that is, do you have a good example of an application package for a KPI or dashboard-driven solution in use today? And the follow-on question is COTS, C-O-T-S, or custom, question mark?
Sure. As I said, COTS products for this space in healthcare aren't really available. There are people who have tried to develop COTS in this space. None of them have been very successful. The reason is healthcare is so vast and diverse that if you develop KPIs for one setting, that may or may not work for another setting. As I said earlier, the processes are so dynamic. Business rules are not standard. Terminology is not standard. Now, if you were to develop something for one hospital, that may or may not work for another. Most of the time, it does not. So you have to do your own homework, do the KPIs. And once you do your own homework, then it's easy for any technology company to put it into a data warehouse and put the dashboards on top of it.
Great. Ashok, I think we have one final question. What is that?
Well, this looks interesting. Dr. Gupta, the question is pretty straightforward. I guess in a provider environment, when we are dealing with multi-vendor situations, who's going to be responsible for meaningful use consulting? The question obviously is who's going to help us with this integrated enterprise. So with so many products and devices, so what happens then?
Yeah, I sort of answered that question earlier also. What you need is, consultants, whether in-house consultants or from outside, but you need people who've been there, done that. You need people who are crossovers between healthcare and technology. These are very difficult to find, but, for a successful implementation, that's really required.
Okay, good. We have a question about technical issues relative to business decisions. And the question is, should technical issues drive business decisions or the needs of the business, including the staff, drive these technical decisions? Does that make sense?
Sure. In my experience, it should be the reverse. It should be the clinician driving everything, not the technology person driving everything. Because ultimately, unless the clinicians are involved in the process right from the beginning, unless they're seen or they feel that they are in control, your adoption will never happen. The project will never be successful if the technical person is seen to be in charge and driving it.
Okay, great. Thanks very much. I think we're at the end here. Ashok, do you have any additional questions that have come in?
No, not at the moment. I think it's good.
Okay, me neither. And so, again, we would like to thank you for your participation today. We appreciate your interest, and we did have some questions about whether or not we will provide a digital copy of the deck, and yes, we will. We'll provide it in PDF form. And at some point, we will, over the next couple of days, post the video as well. If you have any other colleagues who might be interested in watching this video and listening to the Q&A. So again, thank you very much for your participation. Have a great afternoon. Let me see. I've got one other question here. Technical questions. Any opinion on Wi-Fi implementations such as a diverse environment as a hospital?
Carl, I missed that question. Can you please repeat that?
Sure. Do you have an opinion on Wi-Fi implementation in a diverse environment like a hospital?
Sure. Well, Wi-Fi is something that is required when doctors have to move around, making notes, especially in patient areas, and while doing the BCMA, when the nurse has to move around, doing the scanning of the patient's band, doing the scanning for the medicine barcode before administering. A whole lot of movement has to happen, and the things have to happen while moving. That's where you require the Wi-Fi the most. Many times the building is not suited for Wi-Fi and you have a challenge there. But then that is something that you really can't do much about if you are planning to do Wi-Fi after the hospital has been constructed. The only way to do is to have multiple Wi-Fi spots in the building so that you are able to provide the entire coverage. And then Wi-Fi is a very good way of providing mobility to the consultants so that they can do the data entry on their tablets and on their laptops, or whatever device, mobile device that they want to use. I've seen a whole lot of productivity improvement if that is done. There's another way which I've seen, some people call it the computer on wheels. So you basically put a computer on a hospital cart and move it around. And if you can have a power backup source and a Wi-Fi connectivity to it, then it also serves the purpose. It reduces the cost in some ways, and it serves the purpose. Many hospitals prefer computer on wheels versus mobile devices because they fear that mobile devices, there will be pilferage. People will pocket it and sort of take it away, whereas other hospitals, they are okay with the security, and they say mobile devices are better. So that's a matter of choice. However, in the patient area, Wi-Fi is always a good implementation, and it brings productivity.
Okay, great. And with that, and no more questions, we are at the end. So thank you very much. We'll send out the deck and let you know about our next webcast coming up in October, which is a panel discussion on interoperability. In the interim, thank you very much. Have a great day, and we'll talk to you next time. Bye now.